Testing stream 1 2 3. Testing stream 1 2 3.
Who's missing over here? Roger's missing. Okay. Good afternoon. I'd like to welcome each of you today to the board meeting for the Tarrant County Hospital District. Our first thing I'd like to do is our chaplain, Miss Leanne Franklin, if she'd like to come forth and lead us in prayer, and if you'd please join me in a pledge of the allegiance. So, Ms. Franklin.
Welcome, everyone. We gather this afternoon before God and everyone, and we pray this afternoon. We ask for open minds, for open hearts, for clear vision, for wisdom from high. And we ask for sharp focus. Keep us focused on every patient, every family member, every community member who trusts their care to us. Let us be united in everything that we do. All this we ask in your holy name. Amen.
Thank you. I have been advised we do have someone wishing to address the board today, and I hope I do not mispronounce his name. It's Mr. Tim, is it Font? Folt? Mr. Folt, if you'd like to come up to the podium, and I have to advise, as we do with everyone who speaks, that the policy is that we do have a mandatory or a maximum 3 minutes. The podium's all yours, and we won't be able to take any action as far as the board, but the floor is all you, and welcome.
Thank the board for allowing me to speak just on a couple of concerns that I have. I first of all want to point out that Laura Bernstein and Debbie Craig have done a fantastic job in addressing several problems that I brought to their attention. There are different things involved with computers and processes and everything else that mechanically I have no idea what they do, but you know, they've done it, and they've done a very good job, and I don't want to forget Kenny either. The other thing I wanted to point out to you was the fact that one of the things that concerns me is the fact of the regulations on parking garages. As I remember a period of time back, you had a sliding scale based on the amount of hours and everything that you parked in there, and now basically you have one payment system where it's up to 30 minutes it's free, and after 30 minutes it's $4. And I think that's a little unfair. You're a nonprofit hospital. You obviously know the clientele you serve, and I think that that should be reevaluated and readjusted, because a lot of these people are under far worse financial conditions than I am. But I also understand that it can be a big frustration when you sit there and you're there 32 minutes and all of a sudden you're getting dinged for $4, okay? Last thing I'd like to make aware of is the fact that I know that you probably are all aware of this, but it's something that concerns me a great deal because of your image in the community, of the fact that you have served so many people over the years that JPS has been around. And that is the concern about all the migrants and everything that are coming up from Mexico. I feel that probably there's a grave concern of all the amount of people in that area that is going to come up here and flood your facilities, your personnel, and put a strain on everything that's concerned with it and everything else. I think it's time that the board members, along with the members of this hospital, make it aware of the government of what they need to do in whatever manner they can to sit there and stem this, because otherwise we may not have a health system as we know it. Because my biggest concern is all of these different things that go on with all the diseases and everything that you folks have eradicated. Some have given your lives, some have given your positions, and everything else to eradicate these diseases over the years. I fear that that may happen again. So I'd just like to make that aware of it. Thank you. Appreciate it.
And thank you. There being no other individuals who have signed in to address the board, it would take us to item number 4 on the agenda. Excuse me, which is the approval of the March 14th minutes. I know you received them previously. If there's any questions, we'd entertain them. If not, I'd entertain a motion to approve. I have a motion and second by Reverend Emerson. All those in favor say aye.
Aye.
Thank you very much. Now it comes to the part on the agenda where I kind of get to say a couple things that as the chairman's remarks. And the first one I'd like to say is, and I know each month it sounds like all we do is attend things. This organization does attend a lot of things. As I indicated, there's only 11 board members. I'm very happy to say that I did get to attend on the, I think it was the 21st of last month, what is called the Silver and Beyond Banquet. It was another event that was put on by staff, but most important, like we had done the previous month in recognizing the Excellence Awards, it's great to recognize those individuals who have served this hospital for many years. Obviously, the word silver means it had to be a minimum of 25 years, and I think Mrs. Labby, is Ms. JR is back in the back, and she'll have the exact numbers, but I believe there were 47 individuals who received recognition that evening. I think I remember writing down, if I wrote this down right, Mrs. Labby's total was 1,375 years worth of service. That means of the 47 people, I'm a banker, I can do the math, even though Neil may question where I went to college because he went to A&M and I went to Texas, but that's an average service of 29 years. And so it was a great evening. We got to recognize a lot of individuals who have done countless things to help people, human lives in this institution. I will also say that we had 3 individuals that we celebrated that night who had 40 years of service with this hospital. All 3 are RNs. Imagine the impact on the lives that those 3 individuals, along with their teammates, have had in this institution to this community. So on behalf of this entire board, again, I got to be there that evening to say thank you. I'll also want to thank this. Like I said, there's only 11 members of this board. 4 of us attended that dinner. I want to thank Amanda, Dorothy, and Ralph for being there. And I kind of got to, as we were sitting there talking about all their tenure, I think it's nice to know about the board. I think, Ralph, if my memory's correct, you're probably the longest serving current board member we have at about 11 years. I think it is. Yeah, y'all are, 11 years.
That's exactly right.
Amanda had only been with the institution on the board for about a month. But there again, it's a collective, and Dorothy and I were kind of in the middle, about 8 or 9 years each. But I just want to let you know that that's what makes this board so special. We come from a lot of different areas and diversity throughout this community, but yet it's amazing to see that it's still exciting for Ralph to attend something and Amanda just come on the board, and she was also giving her evening to that. So again, thank you to those individuals, thank y'all to the board, but most important, thank you to the outstanding years of service that our employees have given us. Other than that, the only thing I might mention, and we'll move along, we have discussed on the board about, we were so, I hate to use the word, focused on the bond package, and that seems like that was so many, after all the time and energy and effort went into that, it's like that may have been light years away. It was just last November. But we talked about having kind of a self-assessment, a retreat or something after that now. Where's the institution? What are some of the major issues? And so I will be getting a survey out to each one of you here in preparation of that, probably the next 2 weeks, get some of your thoughts. Then we probably will set something up maybe early June. Don't know if we'll do it off-site or here. We may combine something like a governance and HR, Dorothy, that maybe it's not as heavy in June. We might do it during those timelines, but we'll be getting back to you on that. But I know there's been several people expressed certain things that, what do we need to talk about? What are some new issues as we go forward? So we'll be getting back to you on that. And then other than that, thank you for all being here. And Mr. Early, I'll pass it on to you as for the CEO report.
Thank you, Mr. Powell. Appreciate it. We had a great opportunity. The Jordan Elizabeth Harris Foundation donated $52,000 to the JPS Health Network, which is powerful. And the reason that that's powerful is the Harris family lost a daughter due to suicide. And suicide is such a powerful, challenging situation that we face. And unfortunately, those numbers are growing. You can point to a lot of different directions, the stress factors, a lot of other things that our children are going through, and adults as well. but we're losing people to suicide that we should not be losing. So what the foundation is going to do in the name of their daughter who lost her life, that $52,000 will be used for a computer data analytics program so we can get a better idea of trying to figure out some of those earlier signs in suicide through data analytics to try to give us, through the analog process of trying to figure out where our at-risk children are and what we can do to intervene the best as possible to do that. So it's an exciting grant. It's an exciting opportunity for us, and it's also really exciting to reach out to the Harris Foundation. Tom and Eileen Harris are wonderful people, and they just came into our lives in a very positive way, and I can see that relationship continuing to grow. And so we're going to continue to do that. Zelia Ball has played a huge role in trying to work with them. So I wanted to let you know about that and the continued research in sort of the data analytics aspects of a challenge that we all face. And we need every tool available, from computers to hearts and minds and love, to try to figure out how to stem that very difficult situation. In this very room, which is the only room we have to have all celebrations, all meetings, everything that goes on, this room is the epicenter. It definitely speaks to a bond package because this is the room for everything. But not long ago, on the 29th of March, we had our Doctor's Day. And that was a really neat deal. We had all of our doctors who wanted to participate. We came out, and all the executive team served them breakfast. I will tell you that times have not changed because what was the most popular of anything that we had was a diamond-shaped wall in this corner that was called the Wall of Donuts. And I don't know that time can pass up donuts and bacon, and we serve both. And I realize we are a healthcare organization, but there was great cheer amongst the Wall of Donuts. And so we had a great time. Our doctors had a great time, and it was a great time to celebrate why we're here. The gentleman that spoke earlier commented on Debbie Craig and Laura Burnside. I think one of the things that y'all need to know as staff is there are a variety of issues that our patients may have, our guests may have. They may see things differently than we have seen them. They may observe things that we did not observe. Some of them may even have a misunderstanding of some of the things we do or why we do them. But the cases that come up that Debbie Craig handles on a daily basis is pretty phenomenal. And Debbie Craig is a lady that walks on water, because very few times do people come to Debbie and say, I'm very, very happy, and I'd like to describe my happy story to you. It's usually a story of frustration or mad, and Debbie has to deal with all that. And sometimes those kind of caregivers need care at the end of their day too. And I just wanted to let you all know as board members how powerful Debbie Craig is in handling issues that would come before the board or issues that come before us, and what a phenomenal person that she is. So should you see anybody with a name tag on at any cocktail party that says Debbie Craig, I would suggest a high five, definitely, because she's a super person. In her part-time here at Christmas, she's also Mrs. Claus. But don't let that be known, because she spends a lot of time at the North Pole. Also wanted to let you know that we've got our Put Spring in Your Step event, and it is going to be on April 24th, and we take the green space from 11 o'clock to 1 o'clock, and we ask everybody to get out and let's take a walk for health. And get out and get a little spring in your step, get a little movement, get your lungs going the way they should be going, breathe some fresh air, and we want to make sure that everybody knows that. So I'll keep you all up to date with that. I know that some of y'all may want to walk in that or participate in that. And I know that in the past, it's a little awkward, but Steve Montgomery has run that. He did not walk it, he ran it, and he lapped everybody 3 times, and I think he's going for a 4th lap this year. So, Steve, thank you very much for all that you do for that incredible project. And then we have on May 3rd a program that many of you have participated in by listening and watching and speaking at, but we have our Excellence in Nursing ceremony. and that's our Gold Stethoscope Awards, and that takes all of our nurses. 2,300 of our nurses are all incredible, so we have the hard task of pulling a few out that we want to recognize for their incredible teamwork and their incredible approach to patients. Our nurses are phenomenal here, and one day of recognition is not enough, but we do have a special day for them. And from everybody who's spoken, and I know Pastor Emerson and I have done this before, you don't usually go to that event without shedding a tear. It's just a powerful, powerful event that makes you feel good about what you do and what we do for patients. And the legacies of people like Dorothy DuBose and so many of the other nurses that came through this program from their leadership standpoint and their nursing skills are honors to all of us. And if you've ever been a patient in a hospital, the power of those nurses is phenomenal. So we're going to have that event, and we'll let you know. The last event I wanted to tell you about is on May 2nd, and that is our Oncology and Infusion Center. That's what you as board members had a direct play in by allowing us to lease the space. It also allowed us to move forward with projects that are related to not only the bond package, but the initiatives of the Blue Ribbon Committee, and move forward with an expansion of our cancer care, oncology, and infusion. So that facility is down on 8th Street. As Mr. Powell mentioned to y'all before, he takes great pride every time he drives down 8th Street and sees that sign that talks about the Oncology and Infusion Center. That will be from 5:30 to 7 o'clock, and we'd certainly like for y'all to attend. We're having not only our providers and all those that provide the care, we're asking all of our patients to come by and celebrate life and celebrate what you can do when you start beating up cancer in round 1 instead of round 12, and our efforts and everything else that we do. So we're really proud about that. So I know that's a little longer report than I usually have, Mr. Chair, but we have a lot of good things going on, and I also wanted to thank you board members for the participation that you have in our events. Very thankful.
Good. Thank you, Robert. And I would certainly say to Amanda, being relatively new on the board, and Zim, the Gold Stethoscope is definitely a must. You're right. You will cry. The only problem is, as you stay on the board, Robert will be asking you to speak at that. Because Ralph, I know we had that opportunity too. So
it's about this time of year that nobody makes eye contact with anybody at work. I'll still find you.
I'm just warning you and Amanda. Y'all get ready. But no, it is a fantastic event. Thank you, Robert. What moves us to item number 7 on the agenda, and I'd ask Dr. Schrader, Chet, well, I don't see Dr. Schrader. So, report from the medical executive.
We don't have a claim either. We don't have a report because there was no
meeting on this, so we'll pass.
Y'all are at the donuts still. Donuts.
All right.
So we don't have a claim report because there's no updates on the claim.
Yeah, everything's all right. So it takes us down to the committee reports. As everybody knows, we did have a pretty lengthy joint planning and finance committee meeting just, I guess, last week. But Steve, I'll turn it over to you before Sharon comes up.
All right. So we have a couple things on your agenda. We had a joint finance and planning meeting last week, April 4th. Sharon has the February financials. She'll be here to answer any questions about. We also passed one contract that's on consent and a purchasing policy change that's on consent as well. But Sharon is here to answer any questions on the February financials.
So in your packet, we did cover these in much more detail at the Finance Committee, but February was a very strong month financially compared to our budget. You can see that we actually, for the system, we ended up about $900,000 ahead of where we had projected. The hospital for the month had a little bit of lag in volume, so we were a bit under budget in total revenue, but we were also able to create some savings on the expense side. Medical Center ended up about $900,000 ahead. A claim, I circled the wrong one there. A claim ended up about $100,000 and ahead of their budget. And so after interest income, we were about 1.1 million ahead. If you look year to date, the system in total has actually a break even from operations of 455,000. I can't circle it because all my controls are sitting right on top of that number. And if you drop down to the bottom, that's the number I really wanted to circle. If you drop all the way down to the bottom, we're about 8.8 million ahead of our budget plan. Is there any questions? And this does represent 5 months worth of activity.
We're almost halfway through the fiscal year.
We are, which means we're getting ready for budget for next year.
That's the fun time. And that's my report, Mr. Chairman.
Okay, thank you.
Thank you, Sharon.
Sharon, thank you very much.
Wow, Steve, you did a great job.
Yeah. Sharon, you and the staff sure are making Steve look good. Yeah, just keep those numbers coming. Dr. Elliott, if you'd please come up, and we will, let's see, annual academic institutional report. Dr. Elliott, good afternoon.
Thank you for this opportunity to come before you again to give our annual institutional report for our academic affairs and specifically around our graduate medical education. This is a requirement from our for you guys too. And we, of course, appreciate any questions you may have. All right, I'm going to have us go to the next slide. Start our slides.
Yeah.
You don't want to talk about the financials?
Yeah.
Well, let's see, Sharon.
I'm sorry,
That's okay.
Yeah, it's right there.
Thanks, Steve. All right.
My head's right in the middle of that.
Look, there you go.
All right, there we go. All right, so let's just a little overview, again, just to remind you about our graduate medical education programs here at JPS, Tarrant County Hospital District. We're very pleased to be able to sponsor 10 of our programs, residency and fellowship programs. You'll see there we have emergency medicine, family medicine, geriatrics, obstetrics, gynecology, orthopedics, psychiatry, sports medicine, and transitional year, including a podiatry and oral maxillofacial surgery internship.
Tricia, would you do me a favor?
Yes.
For the purpose of our two new
Oh,
board
yes.
members, would you, they're going to know surgery, sports medicine, and everything else, and they may well know what transitional year means, but that's
happy.
going to be the one that's going to be a little out of line from that. If you describe a transitional period, that'd be great.
Great, happy to do so. So transitional year program has been in existence here for quite some time. What that is, it's a one-year program straight out of medical school where they actually apply from medical school to be able to have 1 year and transition to their formal residency program. Most of those that do transitional year fellowships are either going into ophthalmology, radiology, some of these other specialties that require a year of training where they're able to get some internal medicine, family medicine experiences, emergency medicine, so they can get some training prior to going into their main fellowship, main residency programs elsewhere. So we provide that. We get very stellar residents who come through. I will tell you historically, transitional year programs, they have some of the highest academic qualifications that we see in our transitional year program. So we have 12 of those residents annually. And happy any other questions with that. So as you look at this slide here, just to give you a little bit of an overview, you see surgery that's in there. That's actually just the Baylor program where we're an integrated site for that program. They have 47 residents. Those are not all of ours. So what we do represent here on this slide is that we have 209 residents that are JPS sponsored. And then surgery has 14 that we actually support coming through to support our surgery program, integrated program here. So 209 is our total FTEs of people here that we support in our residency program thus far. This slide actually just talks a little bit of where we are in our accreditation. Of course, we want to make sure that we're always maintaining our accreditation. The main accreditation body that we have is the ACGME, the Accreditation Council for Graduate Medical Education. Additionally, there are other programs such as the Council on Podiatric Medical Education that also accredits our podiatry program, and then our OMFS, which is collaboratively working with our partners elsewhere. So what we look at in terms of our ACGME programs, we're really proud to see that we have continued accreditation across the board. The institution also gets reviewed annually, and we have to submit that annually for our own continued accreditation. So with that, we're pleased to see that we are definitely doing very well. We have several of our programs have received commendation actually from the ACGME. That includes our family medicine program, our sports medicine program, our geriatric program, and our psychiatry program. We were so proud this last year to get their first commendation from the ACGME. We have been able to really shift many of these programs this year from some citations and areas for improvement that did pop up. So actually, everyone has really done a remarkable job. We had 2 areas of citations on scholarship, and I'll talk to you a little bit about the initiatives we've done on scholarship as a whole, as an institution. That was in the area of transitional year and also particularly looking at OBGYN also. So we were really able to get those citations removed this year, and we have orthopedics. We're working closely with them on one citation around their hip and pelvic surgeries. Everyone has really done a remarkable job to shift and continued accreditation. Yes.
This is approximate date of next site visit.
Yeah, let me tell you, yeah.
And that's, go ahead, sorry.
Yeah, happy. Thank you for pointing that out. I meant to mention that. So we're still awaiting some notification right now from the ACGME. Looks like they're about 10 to 12 months behind schedule. Okay. So we've just been in the waiting game right now for family medicine, sports medicine, and geriatrics, but we're trying to do continual readiness. What we do is we also perform mock site visit preparation. So the GMEC really owns that so that we can get everybody ready. So we usually conduct that around 3 months prior to this time. So we should get a 90-day notification from them, and so they have time to still continue to prepare. The one group that did get theirs in November was podiatry. So they had their site visit in November, did quite well. They were really impressed with the sponsor, the institutional support, and what they saw. We're awaiting the final letter from them, and we're hoping to see that this month.
Great. Okay. Thank you.
You're welcome. Yes, Reverend Emerson.
John Stella, OMFS.
Yes.
They did have the site visit.
So they are not under an accreditation, CODA accreditation here. That was a partnership of a site visit at Parkland's program. So we do get Parkland residents that rotate with us. So they had at the Parkland site their OMFS program. We put it there because we also like to know that they're doing well. If we're getting those residents, we want to make sure they're having a fully accredited program and doing well. And per their CODA accreditation visit, they did well. And that's from the Parkland side. We get 5th years and 6th years that come to us. And then we have 1st years internship that are here, five interns that are here that we sponsor. Any other questions on this slide?
Yeah, on OBGYN?
Yes, ma'am.
They won't be back until 2024?
Yeah, so we have a whole different cycle right now with the ACGME. Now, we're hoping, we could see that it could always change. They always have a chance. That's why we do a continued accreditation cycle, because we have to submit data every year, and then the residency committee of each specialty reviews annually. And they'll make a decision around continued accreditation, or do they want to have more information and do a focused site visit. Luckily, we've been good, and they've really appreciated all of our submission and our data. I review every single program's data that's submitted at the DIO level. And so, yeah, we're expecting them to come 2024. They do a 10-year cycle now in the ACGME.
Okay.
Any other questions? Yes. All right. We're going to move on to the next slide. I wanted to give you a little bit of a brief overview. We had our ACGME Clinical Learning Environment Review, or our CLEAR visit. You heard us talking about that a lot in anticipation of that visit last year. So that occurred in April of 2018. That occurs every 18 to 24 months. They were actually probably shy of 3 years, so they were a little behind on that, but we are making sure that we're ready for them every 18 to 24 months. So I could be talking to you again about this in another few months. So these are the 6 areas that we review and that they took a look at, and they did a 2-day visit with us, as you see. So patient safety, quality, and under healthcare quality, they also reviewed healthcare disparities, care transition, supervision, well-being, and professionalism. And this is where they had small group sessions with residents and fellows, with faculty and other staff, and also with our executive suite and C-suite. So with that, they provided a report, which we provided to you guys earlier. And we did fairly well. This was our third CLEAR visit, and we actually progressed in all these key areas. We've actually created a dashboard where we looked at our patient safety and quality outcomes and what they reported in their data report compared to the 2016-2018 national findings, and we've done fairly well. There are some key areas that we want to continue to work on, and that actually is focused more so in the quality area. So things that they pointed out were just making sure that we're increasing reporting of our near misses and close calls, and then also interprofessional quality projects. So looking at some opportunities from an interprofessional team to do some work around that. Also seeing how we can make sure that our residents and fellows have access to their quality data individually. And then also looking how do we enhance our healthcare disparities and really making sure that we have specific quality projects that are focused on healthcare disparities. One of the things they pointed out is that understanding that we are a safety net hospital and we do care for an underserved population, but they want us to see very focused things and focused projects on our healthcare disparities and how we're really addressing the idea of health equity and building that.
Who's defining what those healthcare disparities are? Who's that person?
Yeah, so they have some guidance around that within the ACG and CLEAR, and those are kind of some of the national conversations that are happening. But what they're actually looking at is they want it to be individualized to the organization. What are you seeing within your own communities that you have identified, whether through your community health needs assessment or otherwise, and how are you addressing the care and the disparities seen in your own patient population? So the key is that they want us to really make sure we're doing true population health and that we're identifying the gaps in care of those areas, and that what are we doing in terms of specific quality improvement projects to address the gaps specific to our patient population.
Then who's the we that are looking at that from here?
From here, that's where the conversation, I think, in terms of our healthcare quality and how we're partnering around that in terms of all the aspects from our quality team, patient safety and quality team, population health. And also, they were very impressed that we are actually, within our department, we have the Center for Outcomes Research, and we actually mentioned that to them, and it was a high positive value to them to see that we actually had a research team who are looking at specific areas around that in collaboration with the other departments. So I agree with you, Reverend Emerson. I think this is an opportunity for growth that we're continuing to actually explore, that we want to make it's a collaborative model to do that.
Yeah, I do have some concerns.
Sure.
With that area. And especially Steve and I have talked, we had an opportunity, Steve and I, and Amanda to sit at a meeting, and as we talk about the social determinants of health, I think it collides with each other.
Absolutely. Absolutely.
So I would hope that there could be a stronger conversation about that as we talk about healthcare disparities.
Absolutely.
I guess my concern is that you have the right person at the table who are helping define what those disparities are.
Right, absolutely. And I'm happy to help in any way we can do that to ensure that the residents are fellows and part of that too. Glad to help.
Before you move on,
Yes.
how do you address how do you measure the well-being?
Yeah, so this is a new area that they're looking at in this recent iteration of the CLEAR visits, that they've really defined it around that. The way that they define well-being per the ACGME, what they looked at was work-life balance. They also looked at fatigue and how we're mitigating fatigue in the team and the individual. Also looking at burnout and rates around burnout. And lastly, the thing that they were really also focusing on is how we identify the risk for harm, self-harm. And so what was great about the opportunity for us was that we were able to highlight our collaborative model that we've started. We were actually told we were ahead of a lot of other organizations in the country because we really had started some things where we worked together not only with our academic affairs group, working collaboratively with spiritual care and ethics, working collaboratively with our EAP group and our other faculty. And so putting that together in terms of a well-being committee was actually a highlight for them to see that we're working on this deliberately. So we do have a new director of interprofessional well-being. They were very pleased to know that that was coming on board, and Dr. Matinda has joined us. And we are going to be measuring this, looking at well-being indices. That's some validated tools around that. How do we start to measure that and track that? And we want to be able to present those to you in the near future.
Okay, thank you.
Yeah. I'm going to move us on just to give you a little highlight of our board pass rate, which we, of course, always track that. And so we like to make sure that we're between 95 to 100%, and we are 99% this last year. We just got the last set of data in from emergency medicine, and so we're pleased to report that we are 99%. All right. Let's talk a little bit about graduate practice locations. We're actually working very diligently on building some graduate data. Our team has worked, and we hope to bring that in the future, where we're looking even retrospectively at some graduate data. So our research team, along with our library team and academic affairs, we actually have some broader data that we're working on so we can create a database. So we're pleased about that. But this is our 2018 JPS graduate report. So just showing you in terms of where they're locating. And of course, this is always something we like to look at. And you'll see that about 27% stayed in the Tarrant County area. We had overall around 56% in the state of Texas and 44% that went out of Texas. We like to make sure that most of them are staying in Texas, because that's where our Texas folks likes to see that, and also our other bodies, not only us as a hospital district, but not our state legislatures like to see that number too. So it's good for us to see that that's happening. We're doing definitely some active strategy around increasing that number, particularly that JPS number. We'd like to see that go from 4, those were 4 individuals that stayed last year, and I think we're going to really anticipate a larger number of 2019 graduates here. There've been some active work, and I want to thank my great partners in our physician groups, such as with IES and with Acclaim and others that are really helping us to move that number forward. So we've been talking very diligently around moving that number up.
So that was 4 out of how many graduates?
69.
69.
Mm-hmm.
I also had another question from the larger report that was resident demographics of male versus female on page 19.
Yes.
How did those statistics for 2018 match up to national statistics?
So we're slightly above on the male side of for national, but we actually, some specialties actually also have more distribution across gender than others. For instance, there are some national moves looking at orthopedics. It's a highly male-dominated specialty, usually in the 90% of men and lower. So there are some larger initiatives happening at the national side to move those numbers. And those may kind of skew our numbers a little bit too, in terms of just knowing that we've got certain specialties represented here too. But we're looking at that, and I think as we do and grow, I think nationally we're looking, the diversity and inclusion piece is actually a big piece in our strategy coming up, because it's not only the thing that we need to do, because I think highly valued, and we're having a lot of conversations around our recruitment of diversity and inclusion, but it's also a national movement around diversity and inclusion happening. Yeah.
Thank you.
Great. Yeah. Yes, Reverend Emerson.
Is there something we're not doing, or something we can start doing to increase the 6% and reduce the 44%?
Yeah, I think those are the things that we're actively having those conversations about, and I've met regularly, as I said, with our physician group leadership looking at that, but there are some other strategies. I think the thing that we need to think about also is also not only, it's the match piece, right? So it's not only the graduate piece, it's the match piece, making sure that we're seeing more diversity there too coming in, that maybe more local folks, right, that are coming in and want to stay home and want to stay closer to home. So I think we look at the continuum of the recruitment, not only those coming in and how to retain those. I think also we're looking at some strategies around faculty. I think our faculty are a big draw for people to come and to stay. So if they see like, oh, I see somebody who looks like me, or he's kind of practices like the way I want to practice, and I kind of want to stick around and be a part of that group. So I think it's going to be a collaborative, and I will really welcome any other input that you guys have. But this is my 2019-2020 focus, to really try to move those numbers. And so I'm actively going to work on those. But as I said, I think I'm pleased that hopefully this year we're going to see a significant jump in that, just based on the early conversations. Anything else?
Any other questions, Dr. No, I'll wait for a little bit, because
Next one?
Okay. I want to make sure that I tied it, because a certain program that we rank pretty high, and it requires to get top students from top schools, so they may not be part of the area, but they do train and service and train other people. So it has other benefit also as well than from just being here. I just want to see how, in the next few slides, I'll have some more questions on it.
Will do.
Reverend, can I make one comment? So I want you to know that even the 6% may be a little low on the surface. You know, one of the things, for example, in emergency medicine, we have a residency training program. We actually encourage our residents to go practice a year or two before they come back and train. So a number of them will come back later on, 2 or 3 years into the career after they've served the community, and come back and then be able to participate in the academic program. I'm sure family medicine, orthopedics, those kind of programs are doing a lot of the same things. So this is just, to my understanding, how many get a job immediately at JPS the day they graduate. And we kind of encourage a community experience and going and serving the community before coming back and now teaching the new residents how to do that as well. So I imagine the number's probably a little bit artificially low.
And to that point, I think I knew that we had that policy, and it actually enriches things. You study in the program and then you become part of the program. Sometimes it's helpful to go to other schools. We've had a few of our residents, I know, in trauma go up to Denver Health, that switch and then back. But I think it would be really important for us to track the number of JPS residents that do come back, so that we can at least do an asterisk to that slide.
Yeah, absolutely. And that's actually the graduate database that we're compiling right now, and that with the research. So we are compiling a retrospective database so we can actually do that very thing. And it's early in its phase, and I think we have gotten a lot of really great data, and our research team did an incredible job. So now that we can actually run some of these types of reports, and we can create this database, that we can be able to present that to you in a future.
Yeah, actually one of the reasons I also asked that is that I can see there's a culture inside the hospital that hopefully will attract them to want to stay or want to work. But then there's also a culture outside the hospital that I think that we might want to connect with, so that they would say this is really a great place to live also, to practice. So
great points. Yeah, great points. Thank you, Reverend Emerson. Thank you, Dr. Schrader.
Before we move from that, it seems to me if we're talking about family medicine staying, I was looking to see on the financial report, it looks like you have 13 openings. So if we are graduating family medicine, even though we might want them to go out, they would get a lot of community experience here. So I would be interested in looking to see why, if you have 13 openings, no one is taking your family medicine.
So I think that number actually will move, and I think we've actually lowered that number down to 13, and I'm pleased to know that Dr. Fowler and Dr. Hochberg, along with Diana Prachel, have been working very closely on moving that number. So I think this coming year, we'll see some folks that actually have some letters that are pending, and that will actually remain within our family medicine. So that's where those active conversations are happening, but we will go ahead and continue to take a look at the numbers there and see how do we get that. One of the things we're also looking at, and our claim leadership and myself have talked about, is even looking at our recruiting strategy and getting really in front of them. And so we're going to be doing some really fun, innovative, cool things coming up in this next academic year to really get in front of the residents even more and collaborate on that.
I would ask, as you start tracking that information,
yes, ma'am,
I'd like to see how many stays, and of those that stay, do we have a turnover in that number?
That's a good try. We can definitely look at that.
I have a quick question while we're asking for family practice.
I'm sorry?
Can I ask a quick question on the
yes,
family
please.
medicine program?
On the family medicine program?
Right.
Okay, yeah.
We, everything that I look for, included on our website, it shows 2014 data for the ranking. Do we have the latest ranking?
Yes. The latest ranking that we have, it comes out of Doximity, which relates to that, is number 5 in the nation.
Number 5.
Yeah.
Okay. All right, thank you.
So are we going to update our website?
We are. We are actively working on updating our website, Mr. Bose. You're absolutely right. You'll see. Okay. Thank you for that. I'm glad to know people looking at it. That's good. Yes, we are actually doing that right now. All righty. I like that with the turnover. Okay. So I mentioned to you that we actually had a couple challenges previously with ACGME around our scholarly activities. And so really as a whole, just taking that as an organizational goal, and I'm so pleased that we were able to do that, seeing that our academic pillar really owned the idea of scholarly activities. So this is collaborative across our whole academic affairs and research departments, so our Office of Clinical Research, our Center for Outcomes Research, Academic Affairs, Library, CME, all of us pulling together to really increase the number of scholarly activities. And we're tracking that monthly and reporting that to you monthly. This is our latest number. Our year-to-date number is 56. You see our target and our stretch there. So we are truly on track. We are also doing active work with all the different departments. We're also now working with nursing too to make sure we capture everyone's scholarship across the board. That way we can not only capture it as an organization, but we're able to feed it back into the programs for them to report it in their upcoming accreditation documentation in August. So we continue to do this, and we're also pleased that our research symposium is happening June 7th, so we hope to see you guys there. And speaking of health disparities and health equity, we have really decided that we want this year and next year and the next couple of years to really focus on the research around that. So the title of our research symposium is Fostering Health Equity Through Research and Practice. So we're going to really try to drive this so that we get in front of this and move this forward. We have a couple speakers. This is kind of planting the seed to kind of get us kind of stirred up around this to move this forward. We did have over 100 abstracts submitted this year. So went up from 47 last year to over 100. So we're getting some traction on that one, and I'm just so excited about our team doing this. Any questions on our scholarly activities?
What's the date of that?
June 7th, I believe, and we'll send it out again for you guys. Yeah. All right. Yes.
I'm sorry.
Back on scholarly activity. Yes.
No, actually, can we go back because I didn't see the ethnicity statistic and all that stuff.
I did not put it in the slides, but it is in your report.
Mm-hmm. Right.
Yes, and so that is going to be part of that whole diversity and inclusion piece that we have to actively work on. And I'll be actually having some conversations already with Ms. Michelle Green-Ford, working with our diversity group. But we are definitely going to be tracking that and looking at those numbers. And hopefully you did see some of that data in the report.
My question is there anything changed from 2017 to 2018 that result in a pretty big drop from the African American?
You know, no, and that's where I think the strategy around our faculty recruitment and diversity around our faculty recruitment plays a huge role, and those are some of the conversations. Nationally and in many studies, it shows that our residents of color, we have a national issue around what they call URM, underrepresented in medicine. And that is in terms of looking at our residents of color, particularly looking at African American, Black residents, Hispanic, Latino residents, Native American, and looking at that group of underrepresented in medicine. So there's a national push right now because unfortunately the national statistics are flat. So we're still at about 8% or so with regards to African Americans, 8 to 10%. We're still flat on the national recruitment into medical schools with Latinos too. They've been a slight increase, but not much. The increases have been in the Asian communities, and then it's also a slight decrease in the white community for students. So it's a national discussion happening at the ACGME, the AAMC, at the professional organizations, the teaching organizations. How do we move the URM stats? So we are also going to be partnering and looking at that. We have to look at that, and so I'm also going to be gathering that information. What are some of those initiatives nationally to look at that? We are already talking about some recruitment strategies in academic affairs that we want to get in front of to see if we can just make ourselves more public around certain areas where our students of color actually go, and really making sure that we build some partnerships with those organizations. So I'm open and very open to your ideas. And as I said, this is really unfolding at a national level because it's been flat. We've actually seen a decrease in the number, in a 40-year number of African American men.
Because my concern is 60% drop.
It's, yes, significant.
That's a very significant
number.
Yeah,
it's really significant. So thank you for pointing that out. All right. So just to wrap up here, this is just a little bit of snippets. We're doing a lot more than this, but we're hoping to be able to focused not only as we're growing our pipeline, looking at these very things. And we've actually, speaking of diversity and inclusion, and working in close partnership with the diversity dean at the TCU UNT Health Science Center, looking at that, as she also has this as part of her strategy. But how do we create pipelines overall for our programs from our current partners here in Tarrant County, and really align that, really making sure we're having a diverse group and academically strong residents, and we want them to serve our communities. How do we get to, we were really focusing on fostering a culture of well-being, a culture of safety and trust, so that they can really truly provide the best care. We know that when our caregivers have really high levels of well-being for themselves, they do better care and higher quality and better outcomes for our patients. So we really need to focus on that well-being piece, which is also, we're required to do so, but it's just the right thing to do. Also, just ensuring that we're promoting our research and scholarship and innovation. We want to really improve the health outcomes for our community. And we still have to keep those 6 areas of our clear visit that I mentioned to you: patient safety, healthcare quality, healthcare disparities, care transition, supervision, well-being, and professionalism in light, and that we're continually doing that. We'll likely be doing some clear rounds, making sure that we're staying continually ready for that. So that is a little bit of a summary, and then more detail provided in your report.
Just a quick question to follow up on the last question I have.
Yeah.
What do you project 2019? Because residency program's already in for the next year.
Yeah, the match.
So what's 2019 look like on those numbers?
Which numbers?
The ethnicity and all that stuff.
The diversity numbers? I have the numbers. I didn't put them in this because that's usually part of our next report, but I can provide those to you if you'd like. I'll send them out to you. They're about the same.
I'm just concerned about that 60% drop. Is there any uptick or anything?
It's about the same. Yeah, and it's reflecting national, unfortunate. Yeah. It's our pipeline. So we're going to go ahead and make sure. That's why we're building some strategy specifically around that.
Dr. Elliott.
Yes, yes, sir.
When I look at the bullets here and a couple other areas that you talked about in recruitment and getting,
yes, yes, sir.
I think that one of the areas that is least talked about or pushed or emphasized, even in high school, is healthcare.
Yes.
Especially in I would say in the minority environment, those kids are not pushed to look at the healthcare field at all, and I think that it's something that we might want to look at as we might be looking at a program improvement 10 years down the road, but because we need to start now to do that. Yes. If we want to improve the diversity when it comes to our doctors and so because I can think back going through so many career days, and this is the one area is not discussed, it's not pushed.
Yeah, okay. Yeah. You're absolutely right, and I think one of the things that we're hoping to do is also kind of build some partnerships around those things, or maybe even look for opportunities to build some programs where we are having those students experience what we're doing and come here and do that. So those are some things I'm actually looking at and talking about. I will tell you that they have a kind of a junior medical school program at TCU, and it's usually students from underrepresented backgrounds that are usually in attendance of that, and I was so excited to be able to participate in that, to get in front of these students and teach them a little medicine. And so I was actually one of the guest speakers and did a whole workshop and gave them little cases, and they learned how to do exams on the cells, and we have some pictures from that. And I will tell you, it's that kind of planting the seed. You know, these are middle schoolers, but they were like, oh my goodness, I want to do that. And they were mostly students of color. And so I want us to get out there, and we have to build these partnerships and these programs and inspire them to stay here to see that they can accomplish this and do this. So you're absolutely right. It's a passion of mine, a strong passion of mine, and I welcome any input. I welcome any support. Connect me with the folks that I need to be connected with. We will do this. I'm grateful to have the partner of Michelle Greenford, too, who knows. She and I talk about this a lot. The partnership, Robert, we talk about this a lot. This is something that is highly on our radar, and I would appreciate your help with that. Thank you.
Also, I just want to bring your attention to bullet 2.
Yes, sir.
I'm not comfortable. Recruit and retain diverse, compassionate, and here's where I struggle, academically strong.
Yeah.
I think we need to be careful of that, because that person may not appear to be academically strong,
Sure.
but get them in the system, we'll find that there is some hidden strength.
Absolutely. And I will tell you, because I understand how that can be read in different ways, and I think there are some always challenges to say, you know, that there are things in a quality resident that we're looking for beyond just academics, right? And so it's not just we look at EQ, we look at all these other things, and sometimes when you have that one little, you know, blemish on your record, you say, are we missing somebody who's very strong? And I will tell you, historically, my experiences that I've been doing this for 20 years is that, yeah, that you can. I will tell you, when I think academically strong, I think about the outcome. Because when they're in that door and they leave here as JPS, they are academically strong. And I think it's up to us to make sure that they're going to pass their boards just like anybody else, and they're going to be incredibly strong. So I definitely understand the sensitivity around that. I guess I think about it in terms of people realizing that no matter what, you being here, whatever happened and where you are, and you're diverse and compassionate, that you get an incredible training here and that you will be an incredibly strong resident. But I will definitely keep that in mind. It's those conversations we're having on the recruitment side to make sure we're not missing any exceptional candidates. Yes.
The distribution of medical graduates.
Yes.
Coming out of medical school.
Yes.
For the last 3 to 4 years.
Yes.
That they stay the same.
It's, as I said, it's flat.
So there's something wrong with our
It's flat.
It's a drop 60% when the medical school graduates makes.
We'll look at it. I'll look at it, and I'm happy to talk with you offline about that.
Yes, Jeff.
You mentioned healthcare inequities and healthcare disparities. I'd like to know what those are. I really don't know.
I can chat a little bit about that. I know things that have popped up as we've looked at. So specifically, some of the things, for instance, in our Center for Outcomes Research, we're focusing on specific areas. So care in terms of cancer care. And so there are some national data that we also reflect similarly with national data around things like breast cancer, prostate cancer identification, and the disparities across different populations. And so we do have some of that reflected there. We're tracking and looking at that. We also, and working with our population health team too. The other thing is cardiovascular care. I think diabetes and cardiovascular care, there's some gaps in that. There are some gaps that have been identified nationally around maternal care, maternal health care. We're going to have to look at that a little more closely here. We're not really clear about that, but that is a national trend that we've seen there. And HIV. And HIV is another area, too, that we're looking at, too. So I think also based a little bit on our community health needs assessment, but also what we're seeing in terms of the data. And I'll get back to you with our match, because I can send you our match information and even tell you before I leave here.
Any other questions for Dr. Elliott? Dr. Elliott, very good report. Thank you for your passion and what you do for your leadership and your staff. I have to ask one question. Last year's academic symposium, was it the one at Tarrant County College or the one you had?
Yes.
I was going to tell Ralph when he goes, I went to that last year, Ralph. It didn't take me long to realize I had no way to talk to anybody in there. They were so smart. It was a room full. So I hope you enjoy it, because I didn't stay very long, because I couldn't. I mean, you had some unbelievable topics and speakers, and it was a great program. So again, thank you very much for your leadership.
Thank you for the support, and I look forward to working together more.
I want to thank Dr. Elliott for some of the new initiatives she's creating. I appreciate the partnership with Michelle Green-Ford. Those are two good folks working on diversity issues within our community. I think our residents should do as well as we possibly can to mirror our patient base. When you are an African-American female and your doctor is an African-American female, there may be some real strong synergies there that will help your overall health care. You'll understand the nuances of society's norms and what takes place and how families deal with families. And so I know that Dr. Elliott's going to work on that. I also want to thank Diana Singer. Diana is the quiet one sitting in the back. She's actually only quiet during a board meeting because she is aggressive and strong and powerful to our program. And Dr. Elliott has done some good things in that time period, and that's why her leadership role continues to change here at JPS, because she's a strong leader. Again, Dr. Elliott, thank you very, very much.
Thank you very much.
Appreciate your report.
Next item would be actually number, I guess it'd be 10-2. We're going to hold off on that one for a
few moments for some discussion and come back, which will take us down to item number 11 on the agenda, which is a consent agenda. I know you've all had time to hopefully read it and look at if there's anything that needs to be pulled off, let me know. If not, I would certainly entertain a motion for approval. I have a motion by Reverend Emerson, a second by Mr. Montgomery. All those in favor say aye.
Aye.
Which takes us down to item number 12. Mr. Adams, that'd be the general counsel's report.
The only thing I have is our monthly report. There were posted on your website, board website. There was a list of 36 contracts that were under $500,000. And anyone has any question on those, feel free to give me a call. Thanks.
Thank you for your report. Which will take us down at this point in time. We do need to have a closed session. Hopefully it won't take very long, but there being no other discussion at this time. I'm sorry, Ralph, go ahead.
Before we go to closed session,
Yes.
Could I just make one?
Sure.
I just want to say I had the opportunity to attend the National Hospital Association Conference, and I want to thank Pia and Michelle Greenford. I was invited to speak on a panel on diversity and its impact on board and community, and they provided me with some information I was able to share on where JPS was, and many hospital leaders were amazed and are asking for our information to take back to their facilities.
Great. Ralph, thank you for those comments, and thank you for your service on that board.
Mr. Chair, did we skip 10-2, or is it in?
That's one we're going to come back to. Yes. We're coming back to 10-2. We're not going to deal with it at this particular moment, which would take us down to the consent. So at 2:05, we'll take about a 5-minute. We'll come back and hopefully finish this up. Yeah. Yeah, DT, we're coming back to that one. thank y'all very much. We will now reconvene in open session at 2:46. And we will back up and address an issue that we had not addressed previously, item number 10.2 on the agenda, which is, you can read it there, present to the JPS purchasing goods and services. We're talking about the approval of the elevator maintenance agreement between the Tarrant County Hospital District, JPS, and SW Elevators, Inc. Mr. Early is available, so is Mr. Adams. Are there any questions or comments? We're certainly open for that. There being none, if there aren't any, I would certainly entertain a motion. Have a motion by Mr. Zimmerman. Second by
Mr. Chairman, in that motion, Mr. Zimmerman included the two parts: approval of the exception of competitive bidding related to health and safety, and then two, the approval of contract.
Yes.
Okay, thank you.
With those incorporated in, I have a motion and a second. All those in favor say aye. Opposed, no. Thank y'all very much. We will now move to our appointments. And Dr. Schrader, the floor is yours.
For your consideration, we have requested medical staff privileges.
Everyone's had those provided to you, and any prior discussion, there being none, I would certainly entertain a motion. I have a motion by Mr. D.T. Nguyen, a second by Ms. Dorothy DeBose. All those in favor say aye. Aye. Those opposed say no. Is there any other business to come before the board at this time? Thank you for your attendance here today. There being none, we stand adjourned at 2:50. Thank you. And Dorothy, we made your timeline. We did, Dorothy.